Hello, good evening to all. Whether I'm audible to you people? Yeah, I think I'm audible. Yes, Susha, good evening. Manga, good evening. Pranita, Shyam Sundar, welcome to NORCET mains classes. Yeah, today is a very important topic that I'm going to discuss. Okay, I want all of you to carefully listen to the content which I'm going to teach today, and this will be a rapid revision class. Nothing like I don't want to dig so much on the concepts. Just I'm giving you a rapid revision. This will so that you can quickly revise the important topics before your NORCET mains. And also these classes are going to help for RRB, those who are going to give your RRB exam in the future, and for those people also my classes are going to help, right? The same classes. That's how I'm framing the classes, right? So kindly share the link of this class to your friends, those who are giving the exam in the future. So let them also attend for the today's class. Yeah, good evening to all. Good evening Pavani, Shyam Sundar, Aditya, Josh, right? Yeah, thank you Shubho, thank you. Yeah, I'm good. Priya, how are you? Yes, I'm fine. Lalita, Lokesh, hi. Shobana, Arun Kumar, yes, hi Arun. Manikanta, yes, how are you Manikanta? After a long time seeing you back on my live sessions. Thank you for attending. Bandaru Ratnakumari, yes. Oh, thank you so much. I'm sorry, I made you people to wait a long. That's a long wait from your side. Yeah, I'm fine, Varlakshmi. Okay, so Vinita, yes, I'm fine. How about you, Mrs. Trojan? Yes, welcome back. So happy to see you. How are your duties going on? Hope so you're doing good. Okay, and Kalpana, good evening. See, MSHRB classes very soon. Okay, I'm planning. Let me concentrate for my NORCET exams first. Now also simultaneously will be taking this MHSRB classes. Okay, don't worry, I'll come back with my MHSRB classes very soon, maybe by this week. So నాకు ఇది చెప్పండి, లైక్ ఏ సబ్జెక్ట్ నుంచి క్వశ్చన్స్ ఎక్కువ వస్తున్నాయి ఎంహెచ్ఎస్ఆర్బి ఎగ్జామ్లో? ఏ సబ్జెక్ట్ నుంచి క్వశ్చన్స్ ఎక్కువ అడుగుతున్నారు? సో లెట్ మీ ప్లాన్ దట్ సబ్జెక్ట్ దిస్ టైమ్. So those have already attempted the MHSRB exam the previous time, just tell me community. Okay, right? Obstetrics, community. So what are the major subjects? That means majority of the questions are coming from MSN, CHN. Okay, pediatric, OPG, research. Okay, I'm getting all the subjects. Microbiology, even microbiology for MHSRB exam. How many questions did they ask? How many questions you got from the previous MHSRB exam? Just tell me. Okay, MHN. Yeah, sure, Manikanta, I'll take psychiatry also for this mains. Don't worry, already my videos are available. I did not remove it from my channel. It is available. You can go check those rapid revision videos. That will be greatly helpful for you people. Yeah. Yeah, they're asking all the subjects we know. Obviously I need to plan, I should think and plan. Obviously. Let me see. Just a minute. Let me share the link. Yeah, sure. I'm telling you, no, Jyoti, I'm telling you, that's my assurance. I'm going to take the MHSRB classes also. Even the response was very good from your side. The last time for MHSRB classes that I have taken, I got a very nice response from you people. So that even this time I'm planning. Yeah, very soon I'll be coming to you with the live sessions. Okay. Yeah, good evening, Nursing Pilla. Good evening. Okay, right. So do share the link of this class. This class is going to be a very important class, and this will be a quick revision. Okay, quick go through before your mains exam. I want all of you to carefully listen and make the notes along with me simultaneously. Right? Okay. Okay, thank you so much, Prashant, for your comment. That means a lot for me. Yes, even I am telling you that, right? All my old videos I'm making in such a manner that it will be helpful for future exams also. Only any updates or any new content, if it is getting added, I'll be inculcating that in my new classes. Otherwise, you can follow my old classes also for your exams. Yeah. Thank you means a lot again. It's my pleasure, Mrs. Trujan. Means a lot. So do recommend to your friends. So let them join. Anyway, you have cracked your exam, and similarly, simultaneously also motivate your friends to crack the exam. Okay. Yeah, Rohit. Okay, so let me not waste the time. So stop commenting and then start writing along with me. Okay, if you have any doubts, you can ask me then and there. Starting with my favorite topic, one of my favorite topic, bleeding in early pregnancy. Okay, now I want you people to answer me everything. You people had given already the prelims exam, right? Now your your masters in OBG, and I mean in all the subjects. Okay, right? Let me check how much you have gone through for your prelims exam, right? So right now, starting with the topic, so please watch this video till the end. I am sure you are going to get questions. These are all the cases I'm giving you. For sure you are going to get the questions from this session in your mains exam. Okay, I want all of you to make the notes along with me, right? Okay, so yes, all your doubts, I'm not going to see the comment session from now. I'm going to only concentrate on my content. Okay, only I'll be seeing your answers. That's it, right? Okay, if you have any doubts or if you want to ask me any technical doubts, you can ask me in the group or on my Insta. Okay, Insta and the group link for the WhatsApp group link, you can ask me on WhatsApp. Otherwise, you can also ask me on my Instagram. I'll pin that links in my comment description box. You can go directly click on the link and get access to that. Okay, now, right, so now there is a pregnant woman who came to you at 11 weeks of her pregnancy with the complaints of bleeding per vaginum. Okay, again I'm telling you, please concentrate on the class. So if you have any doubts, you can ask me at the end of the session, right? So starting with the topic, So no issues, you can just listen to the content even on duties. Okay, if you are busy, it doesn't matter, otherwise you can, right? Okay, so now there is a pregnant woman who came to you at 11 weeks of her gestation, and then with the complaints of bleeding per vaginum. What all you will think? Okay, as a midwife, what all you will think of? What is a differential diagnosis that you are going to make from your side? Yes, be quick in answering. You all studied this. You are all studied this content. Let us make this as a quick revision. Okay, now tell me. Yes. Okay, so initially, why do you want to think of yeah, okay, let me, since it is related to pregnancy. Yes, just a minute, sorry for interruption, there is a small interruption, sorry, just a minute. Okay, now bleeding in early pregnancy, what all you will think of? So yes, there are obstetric causes. You can think of the conditions related to pregnancy or which is not related to pregnancy, right? So there might be obstetric causes, or there can be non-obstetric causes. Right? What are all the obstetric causes that you will think of? Now tell me. Yes, you people are most of you are right. See, APH, don't answer antepartum hemorrhage for this. This is bleeding in early pregnancy. See, antepartum hemorrhage is bleeding in late pregnancy. You can call antepartum hemorrhage. I know you people will be answering antepartum hemorrhage for this. Please don't answer antepartum hemorrhage. Antepartum hemorrhage in the sense, partum means labor, ante just before labor, right? That means after 28 weeks, after the period of viability, if the pregnant lady experiences bleeding, then that becomes antepartum hemorrhage. Okay, please don't answer antepartum hemorrhage for bleeding in early pregnancy. Okay, right. So what are the obstetric causes you will think of? As you people are, most of you people have rightly answered. Let me come from the physiological aspect. See, which is very, very normal, which can occur and no need, which is not that severe is, yes, you people are right. Yes, most of you are answering it in giving right answers, but let me tell you, come from the basic aspect. Why to go for abortion, ectopic pregnancy, molar pregnancy? Yes, you people are answering in a right way, but yes, I want you to also take this point. See, do you remember implantation bleeding? What do you mean by implantation bleeding? See, during the time of implantation of the blastocyst, on the lining of the uterus, the pregnant woman is going to experience very, very slight vaginal bleed, which is called as spotting, vaginal spotting. So this is called as implantation bleeding, or it is also called as placental sign or Hartmann sign. Yes, okay, right, which is not pathological. Okay, this is not pathological, which can be seen in common. Okay, right, which is implantation bleeding. At the time of implantation, the woman is going to experience slight vaginal bleed, that is called as implantation bleeding or placental sign. Next, what you will think of? As you people rightly said, yes, I'll think of abortion and molar pregnancy. Even in molar pregnancy, abortion, yes, BPV will be present, right? Molar pregnancy, again, patient will come to you with bleeding. And ectopic pregnancy. Don't forget ectopic pregnancy. So these are all the conditions where the patient comes to you saying bleeding per vaginum. Okay. These are obstetric causes. Non-obstetric causes can be your polyp in the cervix, cervical polyp, or any erosion in the cervix that is causing bleeding. Cervical erosion, right? So these are the non-obstetric causes. Here we are not worried about non-obstetric causes. Here we are much more worried about obstetric causes, right? Okay, so let me clear the topics one by one. Okay, starting with your abortion. What do you mean by abortion? Okay, what do you mean by abortion? Yes, pregnancy loss before 20 weeks of gestation or before the fetal weight is 500 grams, right? So then that is called as abortion. Okay, what do you mean by abortion? Abortion is pregnancy loss before 20 weeks of gestation or before the fetal weight is 500 grams, which is said to be as abortion, right? Again, see, for spontaneous abortion, what is the cutoff? What is the cutoff for spontaneous abortion? Just now I told you, right? It is 20 weeks. It is 20 weeks. Whereas for induced abortion, for spontaneous abortion till 20 weeks. Whereas for induced abortion is nothing but MTP, medical termination of pregnancy. It is till 24 weeks you can induce abortion. That means abortion can be done. This is induced abortion, which is legal. Okay, as per 2022 amendment in India, abortion can be done till 24 weeks. Previously it was till 20 weeks, but now it is till 24 weeks. Okay, do you remember all these things? Right, till 24 weeks. And one more important point that you need to remember in MTP is there is no upper limit for gross congenital anomalies. Okay, for example, anencephaly, you have done a scan at any point of pregnancy, you have done a scan and gross congenital anomalies have picked up, then there is no upper limit for gross congenital anomalies if the medical board permits. Okay, there is no upper limit. Okay, but the cutoff value for abortion, induced abortion in India, which we are following nowadays, is still 24 weeks, right? Okay, let me come to the MTP later. Okay, now coming to the causes. Now you people should answer me this. What is the most common cause of first trimester abortion or second trimester spontaneous abortion? Tell me. Now you people should answer, be quick in answering. Excellent, Vinita, Radhakrishnan had answered it very quickly. Yes, it is chromosomal anomalies. Yeah, it is chromosomal anomalies. Chromosomal abnormalities. If chromosomal abnormalities have not given in your option, if chromosomal abnormalities have not given in your option, then you have to just see the options for germplasm defect or defective germplasm. It's one and the same. It's one and the same. The most common cause of first trimester and second trimester spontaneous abortion is chromosomal abnormalities or defective germplasm, right? Any one can be given in your option. Please select that. Next, the second one. What is the most common chromosomal abnormality? Now you have answered it as chromosomal abnormality. Now they are asking which chromosomal abnormality is causing spontaneous abortion, in most common chromosomal abnormality causing spontaneous abortion. Excellent, right? Abhilash had answered it rightly. It is, yes, Cyril Para, yes, you people are right. It is aneuploidy. Aneuploidy, right? The most common, see, if they're asking you the most common cause of first trimester and second trimester spontaneous abortion, then see for chromosomal abnormality. If they're asking you which chromosomal abnormality in common causes spontaneous abortion, is aneuploidy, right? Suppose if they're asking you most common cause of first trimester abortion, on whole, if they're asking you most common cause of first trimester abortion, right? They're not specifying here it as spontaneous or recurrent. They're asking you what is the most common cause of first trimester abortion. That's it. Simple question. What will be the best answer? Yes, the best answer will be again this one, aneuploidy. If aneuploidy is not given in your option, then select trisomy. If trisomy is not given in your option, then go for the third option, that is monosomy X. If monosomy X is also not given in your option, then select trisomy 16. Okay, see, the best answer will be aneuploidy. If it is not given in your option, select trisomy. If that is not given in your option, then select monosomy X. If not, select trisomy 16. If monosomy X is not in your option, then you have to go with this, right? Okay, now tell me, what is here they're asking, see, what is the most common uterine cause? Now, what is the most common uterine cause of first trimester abortion, first trimester recurrent abortion? They're asking you what is the most common cause of first trimester abortion or first trimester recurrent abortion. Now tell me, for first trimester abortion, what is the most common uterine cause? Excellent, Pranita, you have given the right answer. It is septate uterus. Septate uterus. Yes, what is the cause of, no, what is the most common uterine cause of first trimester recurrent abortion? It is same, septate uterus. Okay, septate uterus is the most common uterine cause that is causing first trimester abortion, also causing first trimester recurrent abortion. Okay, right. Now tell me, for second trimester, what is the most common uterine cause of second trimester abortion? Second trimester abortion. They're asking you, see here, Arun Kumar, they're asking you the uterine cause. So that's why I'm stressing the word called uterine cause, Okay, most common uterine cause of first trimester abortion will be septate uterus. Also for recurrent abortion it is septate. And coming to the second trimester abortions, uterine cause, for both it is cervical insufficiency or cervical incompetence. Sorry. For both it is cervical incompetence. Yes, cervical insufficiency or cervical incompetence, right? What happens in cervical incompetence? See, there will be painless dilatation in the cervix and the products of conception will get automatically expelled out. Okay, here the mother will not have any pain or any symptom. There will be a painless dilatation of cervix. Okay, and the products of conception will get expelled. That is cervical insufficiency. That is the most common uterine cause of second trimester abortion. Also, it is the cause for second trimester recurrent abortion. What do you mean by recurrent abortion? If anybody asks you what do you mean by recurrent abortion, then how do you define it? What do you mean by recurrent abortion? Yes? Be quick. See, recurrent abortion is greater than or equal to 3 abortions consecutively. Greater than or equal to 3 abortions is called as recurrent abortions. Okay. Now, here they are asking you what is the most common cause of first trimester recurrent pregnancy loss. Somebody was telling, somebody had given the answer previously. Here they are asking you, on a whole, what is the most common cause of first trimester recurrent pregnancy loss? Yes? Yes, yes. Cyril Para and Abhilash, you are right, it is more than 3 times. Manikanta, here they are asking you, most common cause of first trimester recurrent pregnancy loss. Yes? It is Aplar syndrome. What do you mean by Aplar syndrome? Yes, Aplar syndrome is, yes, Vinita, you are right, it is Aplar syndrome. Aplar syndrome is anti-phospholipid antibody syndrome. Okay, right. And what is the treatment for Aplar syndrome? What is the treatment for Aplar syndrome? What is the treatment for Aplar syndrome? See, for Aplar syndrome, the treatment will be, the treatment will be heparin plus aspirin. Heparin plus aspirin. The most common cause of first trimester recurrent pregnancy loss is Aplar syndrome. The treatment for Aplar syndrome will be heparin and aspirin. Okay. Just a minute. Just a minute. Okay. Yeah, now tell me, what is the most common cause of second trimester recurrent pregnancy loss? What is the most common cause of second trimester recurrent pregnancy loss? Yes? Yeah. Just a minute. The most common cause of first trimester recurrent pregnancy, recurrent RPL is, it is, yes, as you people have rightly answered, sorry, it is idiopathic. Yeah, it is idiopathic. Yes, after that your Aplar syndrome comes. Yes, sorry for that. And now just tell me, what is the most common cause of, yes, Arun Kumar had rightly answered that. Yes, it is cervical incompetence or cervical insufficiency. Okay, right. Just now I told you what is cervical insufficiency, right? Okay. Now, see, does infections leads to recurrent abortions? Does infections leads to recurrent abortions? See, infections can lead to spontaneous abortions, but it can never lead to recurrent pregnancy loss, recurrent abortions. Okay, except there is an exception for this, except syphilis. Syphilis can cause recurrent abortions. Okay, there is only one exception, which is syphilis. No, torch will not. So that's why we don't do. See, Pranita, somebody is saying torch. See, we never do torch screening. If anybody, if any pregnant woman, like any woman is complaining of, like is undergoing recurrent abortions. Okay. Recurrent, like if a woman had 2 to 3 abortions, like more than 3 abortions, 3 abortions, then we don't do torch screening. Okay, so because infections will never cause recurrent abortions except syphilis. Okay, again I am telling you, if any patient comes to complaints with this recurrent abortions, in them we are not doing TORCH screening, okay, because infections will not lead to recurrent abortions except syphilis, right? So please remember this. Now, coming to the types of abortion, let me quickly cover the types of abortion. Okay, with a single table again, I think this single table will clear all your concepts on types of abortion. Okay, so quick, just listen to this table, that's enough for your types of abortion. So coming to the first type of abortion, that is, these are all the types of spontaneous abortion. Coming to the first type, that is threatened abortion, right? So what do you mean by threatened abortion? Yes, see, here in threatened abortion, abortion is at a stage where it cannot, the process of abortion had started. Okay, ikkada abortion process anedi start ayipoyi untundi threatened abortion lo, but it is at a stage where it can be reversed. Okay, it can be reversed. Okay, abortion is at a stage where it can be reversed. Okay, so just now the process is getting started. Okay, if you can manage, so the process is going to get reversed. Okay, that is called as threatened abortion. Okay, so just now, so since it's an abortion, yes, obviously there will be bleeding per vaginum. Okay, that is what I told you, right? That is what I have asked you. The first initial question of my this class is, what is the why recovery is possible? Abhilash is asking why recovery is possible. Just now, just let me complete the topic and then you can ask the questions on this types of abortion. Okay, see, here the threatened abortion, I am telling you, the process had just now started, and where the process can be reversed. If you can able to manage this case properly, then the abortion process can be reversed. Okay, since abortion had started, the bleeding also starts. Okay, very light bleeding the patient is going to experience, which is called as spotting. Okay, which will be in bright red in color. Okay, pain may or may not be there. Okay, so the process is getting started, right? Pain may or may not be there, right? So now on examination, okay, on PV examination, os is closed. Yes, so that is the reason why it is reversible. The os is closed here. If it is open, then you and me cannot do anything. The os is open, automatically the products of consumption will come out. But whereas here in threatened abortion, the os is closed. Os will be closed, right? And when you do per abdominal examination, the uterus will correspond to that of, when you check the height of the uterus, it will correspond to that of period of gestation. Since the fetus is, the products of consumption is still inside the uterus. Okay, it is still inside the uterus here in threatened abortion. It has not expelled here. Hi Dozy, good evening. Okay, here the products of conception is still inside the uterus. Okay, has not expelled out. Okay, still inside the uterus. So the uterus height will correspond to that of period of gestation, right? And when you do a scan, transvaginal scan, cardiac activity is present. Okay, obviously the products of conception is still inside the uterus. I can also see cardiac activity is still present. Okay, it will be present here in case of threatened abortion. Okay, right. Again, I am telling you, threatened abortion is abortion. The process of abortion is got started, but it is at a stage where it can be reversed. Somehow, if you can manage the case, that will be reversed. Okay, right. Yes, fetal heart rate will be present. Cardiac activity is present. Okay, on transvaginal sonography, if I do, I can able to see the cardiac activity of the fetus. Okay, and next coming to inevitable abortion. Inevitable means you and me cannot do anything here. The process of abortion had started. at a stage, it is at a stage where you and me cannot do anything and it cannot be reversed. It is irreversible, inevitable, it is irreversible. Okay, you and me cannot do anything, there is nothing to do here, we cannot reverse the abortion. Okay, we can help to clear the products of conception, that's it. Okay, it cannot be reversed. And obviously the patient will come to you with bleeding per vaginum, right? The process had started and the abortion process started and the os also dilated, right? So there will be bleeding per vaginum and obviously there will be pain here, pain in abdomen. The mother will experience pain in abdomen. And on examination, what about the os? Os is, just now I told you, right, os is open, so that is the reason it is irreversible. And when you do pervaginal examination, since the os is open, I can also feel for the products of consumption. Okay, I can also feel the products of conception, right? And see, here the os is just now opened and the abortion process is getting started. So still the products of consumption is inside the uterus, right? When I do when I check for the height of the uterus height will correspond to that of the period of gestation here. Okay, see, don't confuse. Since the products of conception is still inside the uterus, I can able to, the uterus of the height of the uterus will correspond to that of period of gestation. Okay, right. And cardiac activity may or may not be present on transvaginal sonography, right? So now coming to the incomplete abortion. The name itself is telling you something, right? Incomplete. That means here the abortion process had started and few fetal parts got expelled and few fetal parts are retaining inside the uterus. Okay, so here few fetal parts are expelled out and others are retained in the uterus. So that is what they are telling you here. Okay, and when you do examination, yes, here the os got dilated and the fetal parts started coming out, few fetal parts also got expelled, right? Obviously there will be severe bleeding here in incomplete abortion. Here the fetal parts are getting expelled out, right? So there will be very severe bleeding that mother is going to experience and there will be pain in abdomen, of course. And when you see for the os on pervaginal examination, obviously os will be open and I can also see visibly, I can see products of consumption is coming out. Okay, and if I check for the height of the uterus will be less than that of the period of gestation because half of the fetal products got expelled out, right? So that is the reason why height of the uterus will get decreased. Okay, height of the uterus will be less than that of the period of gestation. Okay, right? And cardiac activities, okay, no need to think of. Fetus got expired, fetus expired, cardiac activity is absent. Okay, fetal heart rate will not be present, it is absent. Okay, right? And on ultrasound you can see some products of conception are retained inside. That's how you will confirm incomplete abortion, by doing ultrasound, right? Okay, now coming to the complete abortion. The name itself is telling you complete, the process is complete, abortion process is complete here. Okay, entire products of consumption got expelled out here. So the uterus is empty. Okay, all the fetal parts got expelled out and now bleeding initially it will be present, but yes, since the abortion process got completed, later it gets stopped. Okay, bleeding also eventually the bleeding also gets stopped in complete abortion because all uterus is empty now, all the products got expelled out, right? And when you do pervaginal examination, yes, the name itself is telling you again complete, means abortion process is complete, all the fetal parts got expelled out and now automatically the os will get closed, right? And yes, uterus height will be less than period of gestation, uterus is empty. Okay, that is the reason why the height of the uterus will be less than that of period of gestation. And on ultrasound there is nothing, there will be uterus pura uterus is empty and there is nothing, no fetus, no cardiac activity. Okay. And coming to the last, that is missed abortion. See, what do you mean by missed abortion? See, missed abortion means the fetus got expired within the womb, that is fetus got expired in the uterus and the mother is unaware of that. The mother is not aware of that. Patient is unaware of death of the patient in utero. Okay, here the mother will have dirty brown discharge. Okay, very very important, dirty brown discharge. If your question is saying you dirty brown discharge, then think of missed abortion. Here the the os will be closed. I am telling you, right, the fetus is retained inside. If os is open, automatically it will come out, right? So os is closed here and uterus is less than period of gestation. Okay, so the died fetus will shrink, right? It will get shrunken. So that is the reason why the height of the uterus will be less than that of the period of gestation. Okay, and even UPT becomes negative here. Even if you do an urine pregnancy test, that will come negative. Okay. Next, cardiac activity. When you do ultrasound, there is no cardiac activities. Yes, fetus got expired, then there is no cardiac activity in the uterus. So now coming to the management, let us see the management one by one. Okay, how do you manage this threatened abortion? See, I've already told you, if you can, threatened abortion is that abortion where the process of abortion started, but if you can able to do something, it can be reversed. Okay, so what is the management of threatened abortion? What is the management? Yes, it is not complete bed rest, Arun Kumar. Just you will ask the mother to take rest and avoid the physical activity. You will ask the mother to avoid physical activity, and it is not complete bed rest again. You will ask the mother to take rest but not complete bed rest. Okay, so that's a conservative management in case of threatened abortion. Whereas in case of inevitable abortion, how do you manage inevitable abortion? See, what do you mean by inevitable abortion? Process had started, right? I've already told you, you can do, if you cannot do anything here, just you will accelerate the process of abortion. Okay, you will complete the process of abortion. You will make sure that the abortion process is complete from your side. Excellent, Krishna. You will do an MTP here. Okay, since the os is open, we cannot do anything. You will make sure that the abortion process is getting complete from your side. Okay, you will do an MTP here. And what is incomplete abortion? Here in incomplete abortion, since few fetal parts got retained inside, I will do a suction evacuation and remove the products of consumption out. Okay, suction evacuation. I will do suction evacuation and remove the retained products of consumption out. So that will be the management here. Yes, you have to evacuate the uterus. And next, what is the management for complete abortion? Tell me the complete abortion, how do you going to manage? Nothing, no management at all. Process is complete, right? So just now you will just counsel the patient and send her back home. Okay. Suppose you can give TT injection. Suppose if she is RH negative, then you can administer anti-D. And you will counsel the patient and send her back to her home. Okay, that will be the management of complete abortion. For missed abortion, again the died fetus is retaining inside the uterus, right? I need to remove it out, right? So again I will go with induced abortion. I will induce the abortion by MTP. Okay, medical termination of pregnancy. Right, and I think you people know which method to follow, right? In MTP, till 9 weeks, less than 9 weeks, 9 to 12 weeks, greater than 12 weeks. You remember, right? You remember anything? My previous classes. Okay, if it's if it is less than 9 weeks, you can go with medical abortion. 9 to 12 weeks suction evacuation, greater than 12 weeks is your prostaglandins. Okay, yeah. So that's how MTP will be done. So these are the types of abortion. Please take screenshot at least and keep for your exam. Okay, they'll ask, you will get case scenarios from these. Okay, carefully, if you have missed my explanation, go back. Okay, after this live getting completed, go back once again, watch this session and make at least take the screenshot and keep it. Okay, you will get cases from this table. Okay, right. Okay, now coming to the induced abortion, right? I want you people to carefully listen to this abortion, this very important topic again, induced abortion. Just now we have completed spontaneous abortion, types of spontaneous abortion and the management. Now coming to the induced abortion, which is nothing but MTP. We are inducing abortion, which is nothing but medical termination of pregnancy. Again, we have first trimester methods and second trimester methods. Now just tell me, in first trimester, suppose there is a 7 weeks pregnant woman, what will be the method of termination of pregnancy in her? What is the method of abortion, method of inducing abortion in her? 7 weeks pregnant, what will be the method for termination of pregnancy? Be quick in answering. Medical abortion, right? Okay, so that medical abortion is the most common, the one which we prefer in first trimester, and the one which is most common is, yes, oral pills. That is medical abortion. Means you will hear you are going to give some oral drugs and induce abortion. Okay, that is the most common. If anybody asks you what is the most common method of inducing abortion in first trimester, it is medical abortion. Okay, the one which is best will be suction evacuation. Just now I told you, right? Best will be suction evacuation. See, medical abortion is till 9 weeks. Okay, or you can also take like this, less than 9 weeks medical abortion will be the best method, and 9 to 12 weeks suction evacuation will be the best method. Okay, okay, right. In rural areas, now tell me, in rural areas what will be the method of choice? What method you are going to follow for inducing abortion? Vikram, previously it was less than 7. Now even Government of India made it as 9 weeks. Okay, yes, less than 9 weeks is your medical abortion, 9 to 12 weeks is your suction evacuation, and greater than 12 weeks is your prostaglandins. Yeah, medical abortion, again I am telling you, Tirumal Rao, medical abortion is still 9 weeks in India now. Okay, 9 weeks. Okay, just tell me, in rural areas what is the method that you are going to follow for inducing abortion is, yes, it is MVA syringe. Since in rural areas there will be no electricity, I will go with MVA syringe for this. Okay, for suction evacuation to perform, you need electricity, right? But whereas in rural areas where there is no electricity, how you can perform suction evacuation? So you have to go with MVA syringe. I will just show you and explain you how you have to perform manual vacuum aspiration. Okay, right. And there is one more method which is followed previously and which is not followed nowadays, is menstrual regulation syringe. Menstrual regulation syringe. It is outdated and not followed nowadays, only can be asked for your IBQs in your exams. So I'll show you images just now, just listen to this. And what are the other methods that you can perform is DNC. dilatation and curettage. These are all the methods that I can follow in first trimester to induce abortion. Okay, I can give drugs, I can also select suction evacuation. Okay, if there is no option for suction evacuation, if there is no electricity, like in rural areas, I can go with MVA syringe, right? Or else I can go with this dilatation and curettage. Okay. Now coming to the second trimester abortion. Now forget about first trimester abortion. Coming to the second trimester abortion. Okay, we have medical methods and surgical methods. In medical methods, the best will be prostaglandins. Okay, and the other methods is extra amniotic ethacridine instillation, intra amniotic saline instillation, and oxytocin. What is this? Priya Kandaswamy. See, why are you answering this progesterone for this? What for you are answering progesterone? Progesterone, it is not given for abortion. See, what is the action of progesterone? What is the action of progesterone? So please don't answer progesterone for inducing abortion. See, it will prevent abortion. Okay, progesterone will prevent abortion. What for you will progesterone supplementation you will give in pregnancy, right? So that will, progesterone is for maintenance of pregnancy. It will prevent abortion. Okay, so you will not give progesterone in case of, yes, progesterone is for maintenance of pregnancy, but yes, here in abortion, we have to give anti-progesterone analog, mifepristone. Do you remember mifepristone? Here we give in medical abortion, first trimester medical abortion, mifepristone is an anti-progesterone. Okay, it will go bind to the progesterone receptors in the uterus. Okay, that is an anti-progesterone analog. Don't answer progesterone. Progesterone, if you are giving, she will never abort. Okay, she will never get aborted. So you have to give anti-progesterone. Please be clear of your concepts. Progesterone is for maintenance of pregnancy. It will act as a cement. It will act as a glue, so that it will not let the baby to get the products of consumption to get expelled out. Okay, progesterone will help to maintain the pregnancy. Okay, understood? You have to give anti-progesterone for abortion. Okay, which is nothing but mifepristone is an anti-progesterone analog. I'll tell you just now, I'll tell you each and everything in detail. Don't worry, just listen to this. Okay, so now coming to the first trimester abortion, as you people rightly said, the most common method that we follow in first trimester, that is till 9 weeks, is medical abortion, right? Medical abortion, what do we do here? Here we give a kit. Okay, MTP kit. See this one. This one, see the strip, this strip has 5 tablets in it, right? So 5 tablets. So this one, mifepristone, I think you may not be able to see this. But let me maximize this. Okay, so this is the kit that is used for medical abortion in first trimester. Okay, suppose if any pregnant woman comes to you at 8 weeks asking for MTP, you will just give this kit. Okay, and ask the mother to take this oral tablets. How it is given? There are 5 tablets. See here, how many tablets are there in this strip? There are 5 tablets. So one single tablet of mifepristone will be present here, and remaining 4, 2, 3, 4, 5. All this 4 has only single medication in it, has a same drug in it, which is misoprost. Okay, all these 4 has misoprost, 200 mics each, 200 micrograms each. Okay, 200 micrograms of misoprost will be present in these 4 tablets, and a single tablet of mifepristone, this one. So these are the 5 tablets it will have. Okay, and see, for your understanding purpose, I have attached this image. 1 tablet of mifepristone and 4 tablets of misoprost are present in this kit. So this is a completely can be done, this procedure completely can be done on an OPD procedure. Okay, here the patient will come to the OPD and take this kit and take the tablet and go, right? On day 1, for example, today the female came to you and you are giving mifepristone. On day 1 you will ask the patient to take this single tablet, I told you, right, this one, single tablet of mifepristone 200 mg. You will ask the patient to take orally on day 1, and which is an anti-progesterone analog. I've already told you, right, just now I told you, right, mifepristone is an anti-progesterone analog, right? And on day 3 you will ask the mother to take misoprost. So on day 1 you will give this mifepristone 200 mg orally, and you will send back the patient and ask her to come after 48 hours, and on day 3 you will ask the patient to take this misoprost tablets. Okay, what will be the dose of misoprost? The dosage of misoprost, if it is less than 7 weeks, if it is less than 7 weeks, it is 400 micrograms or 2 tablets. You will ask the mother to take 2 tablets. Okay, see, why 2 tablets? Each tablet has 200 micrograms. 4 tablets, 4 into 2 is 800 micrograms, right? So all 4 tablets has a dose of 800 mg, 800 micrograms. Okay, each tablet has 200 micrograms. So that's why less than 7 weeks the dose is 400 micrograms. You will ask the mother to take 2 tablets, okay, of 200 micrograms each, right? And if what is the route of administration? The mother can take orally or vaginally, per vaginally. But whereas in between 7 to 9 weeks the dose becomes 800 micrograms, or I can also say like this, 4 tablets. Okay, 4 tablets of 200 micrograms each. Okay, here the route is per vaginal. Per vaginally you will ask the mother to take these tablets. Okay, 4 tablets of 200 mics each. Misoprost you will ask the mother to take per vaginally. So there completes the process. So that will the mother will get aborted. So this is the process. On day 1 you will give mifepristone and send back the patient. That is, the dose of mifepristone on day 1 will be 200 mg. And on day 3 you will ask the mother to come back again to the OPD, and in the OPD it is like misoprost will be given, tab misoprost will be given, and the dosage of misoprost will be less than, if it is less than 7 weeks, 2 tablets. You will ask the mother to take 2 tablets of 200 micrograms each, that is 400 micrograms orally or vaginally. So right, so if it is in between 7 to 9 weeks, the dose will be 800 micrograms, okay, or 4 tablets of 200 micrograms each. Okay, you will ask, the route of administration will be per vaginal route. Okay, and please remember there is a teratogenicity associated with misoprost. Can you people tell me what is the teratogenic effect that misoprost exerts on mother when it is given in first trimester? Only for this is a prostaglandin analog, right? Misoprost, it should never be given in first trimester. Okay, usually in first trimester we don't give this drug because it has a teratogenic effect. In abortion you can give because you are removing, right? Obviously in abortion you can give, but usually normally in a normal pregnant woman who is planning to continue, you should not give. Why? Let me come like this. Suppose if the mother has taken misoprost and wanted to continue this pregnancy, it can never happen like that, okay? Because misoprost is a teratogenic drug. What is the teratogenicity that is associated with misoprost? Just tell me, what is the teratogenicity which is associated with misoprost? M for misoprost, M for Mobius syndrome. Mobius syndrome. So once if mother takes this tablet, okay, she can never continue her pregnancy. Okay, she can never continue her pregnancy because misoprost is a teratogenic drug, okay, which will have effect on fetus. It can cause Mobius syndrome in fetus. Okay, this is not in mother, this is in fetus. Okay, it causes Mobius syndrome in fetus, like mainly Mobius syndrome is related with the facial muscles. Okay, just Google Mobius syndrome and just see the images, you will get to know what is Mobius syndrome, right? And what is the act now? So I think you people are clear. On day 1 you are going to give mifepristone, which is an anti-progesterone analog, and on day 3 you are going to give misoprost, which is a prostaglandin analog, and the dosage will be 400 mg if it is less than 7 weeks, 800 mg if it is in between 7 to 9 weeks. Okay, right. And please remember, they can ask you in exam what is the teratogenic effect which is seen in case of misoprost administration in first trimester. Okay, misoprost has a teratogenic effect which is called as Mobius syndrome. Okay, next on day 1 you are going to give mifepristone, and on day 3 you are going to give misoprost, and the process will get completed, right? Abortion process will get completed, but you are going to call back her back on day 15. You will call back the patient, and why you are calling back again on day 15 is for clinical examination. You will do a clinical examination and make sure that the process of abortion is complete or not. Okay, after 2 weeks you will call back the patient and see whether the abortion process is complete or not. If it is not complete, then you will do a blunt curettage. Then blunt curettage is recommended. Okay, on day 15 you can do a blunt curettage and clear the products of conception from the uterus. Okay, right. So this is what you need to know about the medical abortion. Next, coming to suction evacuation. I told you, right, suction evacuation is not for rural areas where there is no electricity, right? Suction evacuation needs electricity, and suction evacuation is done from, already I told you, right, 9 weeks. It is done from 9 weeks till 12 weeks. Okay, it is done with a special cannula. See here, see the image here, this one. Special cannula which is called as Carman's cannula. Carman's cannula. It is done with a special cannula which is called as Carman's cannula, which is made up of a plastic material, and you will attach this cannula to the suction tubings, and then you will perform the suction. Okay, see the diameter of this Carman's cannula. See the image, this is the image of Carman's cannula. Okay, this is how Carman's cannula will appear. It will have 2 apertures. Okay, 2 openings in it, 2 apertures in it. Okay, and the diameter of this cannula should correspond to that of gestational age of the uterus, gestational age in weeks. Okay, the cannula diameter in mm, it will correspond to that of the gestational age in weeks. Okay, suppose if mother is 9, the diameter is 9 mm. Okay, the gestational age is 9 weeks, so it will correspond to that of the diameter in mm will correspond to that of the gestational age in weeks. Okay, otherwise I can also explain you like this. Suppose if there is a mother, like there is a pregnant lady who want to undergo abortion at 10 weeks. Okay, you have to do 9 to 12 weeks suction evacuation will be the best method. 10 weeks, so 10 mm cannula you will take and perform the suction evacuation in her. Okay, the diameter should be corresponding to that of the gestational age in weeks. Okay, and this can be asked in your exams. Diameter of the Carman cannula in mm will correspond to dash. So option A, option B, option C, option D, option. Okay, so which one you have to select? Gestational age in weeks. Okay, in weeks. Suppose if mother is pregnant lady is 10 weeks pregnant, you have to select 10 mm Karman's cannula. Okay, for a 10 weeks pregnant lady, 10 mm you will select, 11 weeks 11 mm, 12 weeks 12 mm, similar like that. Okay, and what will be the suction pressure that you will maintain is 600 mm of Hg. Okay, during suctioning with the Karman's cannula, the suction pressure that is generated is 600 mm of Hg. Okay, right? Now when you will okay, now you are performing this suctioning. Okay, abortion, like in a 10 weeks pregnant woman, you are performing suctioning. Okay, you have, when you will stop suctioning, there will be an end point, right? So obviously inside the uterus you cannot see, you cannot visualize. You will insert this cannula and you will be performing suctioning. When you will stop doing suctioning? Similarly, ET suctioning, how you will do ET suctioning? There will be an end point, right? Similarly, what is the end point for suctioning with Karman's cannula? What is the end point? Yes, tell me, what is the end point for suctioning with Karman's cannula? So just remember like this, I am giving you a mnemonic ABG, arterial blood gas analysis. This is not that. Okay, A stands for air bubbles in cannula. Okay, you can see air bubbles coming into the cannula. And B for bleeding decreases, G for grating. Okay, G for grating sensation. Okay, so this will be the end point for suctioning. That means if you see this, all these findings, then and there you have to stop performing suctioning. That is what it is meant for, end point for suctioning. Okay, if you see air bubbles coming into the cannula or bleeding is getting decreased, then, or grating sensation if you could able to see here, then you, okay, then you will stop performing suction. Okay, now tell me, what are any complications associated with this suction evacuation? Any other complications are associated with this? Yes, there is a complication which is a very rare complication that you can see is uterine perforation. Your uterus can get perforated. Where you are inserting the cannula? You are inserting the cannula into the uterus, right? And you are performing suctioning. This, even the cannula can perforate the uterus. Okay, so okay, that can happen. Not endometritis, my dear. Okay, there is a rare complication I am asking you. It is uterine perforation can happen with Karman's cannula during suctioning. Please remember, yes, it is uterine perforation. Okay, your uterus, you can perforate, there are chances to get the uterus, there are chances for the uterus getting perforated, okay, during suction evacuation with Karman's cannula. Okay, please remember that. Okay, see, if at all during suction evacuation, during suctioning with Karman's cannula, if perforation occurs, then immediately stop the procedure. You have to stop the procedure immediately stop the procedure. Immediately stop the procedure, and what you are going to do is immediate laparotomy must be done. Immediate laparotomy must be done. Okay, immediate laparotomy must be done. See, before insert, how we will do this suction evacuation? Okay, right, first of all what you will do is you have to dilate the os. You have to dilate the os with Hegar's dilators. You will take the Hegar's dilators and you will dilate the os. Okay, you cannot enter As such, you cannot enter with Karman's cannula into the uterus, right? So os is closed. You have to dilate the os first with Hegar's dilators, and then you have to insert the Karman's cannula and perform suctioning, right? So suppose you are dilating the os with Hegar's dilators and the uterus got perforated. Then what will be the next step is, then next step what you have to do is, you will wait and watch. You will not do anything, just monitor the vitals, wait and watch. But whereas during suctioning with Karman's cannula, which is most dangerous, this one is more dangerous compared to Hegar's dilator uterine perforation. Perforation with this Karman's cannula is more dangerous. Okay, what you have here, you will, if at all uterus got perforated during suctioning with Karman's cannula, you have to stop the procedure immediately, and immediate laparotomy must be done, right? Please do remember this also. They can ask you, okay, suppose there is a pregnant woman, okay, who came for abortion, and you have planned for suction evacuation, and you are dilating with the Hegar's dilators, and you have perforated accidentally the uterus, and what will be the management? The management will be wait and watch in case of Hegar's dilators, whereas in case of Karman's cannula, you have to stop the procedure then and there, and then you have to take to the operation theatre. No need to remove the pull back the Karman's cannula back. You leave the Karman's cannula as such. You will take the patient to the operation theatre, and then there laparotomy must be done. Okay, right. So next, I told you, right? I told you about manual vacuum aspiration syringe. So this can be asked for your IBQ in your exam, and this is called as this one is called as menstrual regulation syringe, which is not used nowadays. Not used nowadays. Menstrual regulation syringe, it is not used nowadays. Okay, just remember this image for your exam purpose. That's it. Okay, right. So next, coming to the manual vacuum aspiration syringe. See this syringe, how you will identify this syringe? It has two pinch valves, one above and one below. It has a two pinch valves, right? The capacity of this syringe is 50 ml, 50 cc. Okay, so manual vacuum aspiration syringe, right? It is used for, instead of suction evacuation where there is no electricity, you can go with this manual vacuum aspiration syringe. Okay, done in case of rural areas where there is no electricity, right? I already told you, right? It has two pinch valves. That's how you will identify manual vacuum aspiration syringe. It has two pinch valves. And what is the capacity? What is the capacity of this syringe? Just now I told you, right? 50 cc is the capacity of, 60 cc. 50 ml is for menstrual regulation syringe. This is 60 cc. Okay, 50 cc is for menstrual regulation syringe, and 60 ml capacity is for manual vacuum aspiration syringe. Okay, and the pressure generated will be 660 mg, 660 mm of Hg. Yes, Vinita, you are right. Okay, 60 cc. 60 cc is the capacity of your manual vacuum aspiration syringe. 50 cc is for menstrual regulation syringe. Okay, so these are the points that you need to remember regarding abortion. Okay, this much at least you have to remember before appearing to mains exam, right? So now done with first trimester abortion. Next, coming to the second trimester abortion. Okay, second trimester abortion. Okay, now see, in first trimester for medical abortion, I told you it is a OPD procedure. Okay, for medical abortion, I told you that's an OPD procedure where the patient will come to OPD, she will get the drugs and she will go back her home, right? But whereas here in second trimester, it is not like that. Okay, For medical management, medical management is always oral, right? Like oral and oral, right? Giving oral drugs, where even if you want to give oral drugs in case of second trimester, you have to admit the patient and then only give the oral drugs, right? Okay, so what will be the best method? Medical method will be administration of prostaglandins. Administration of prostaglandins, that will be the best method in case of second trimester. Okay, if anybody asks you what is the best method, if anybody asks you what is the best method of abortion in case of second trimester, it will be medical method, that is administration of prostaglandins. Administration of prostaglandins. Okay, here what is your intention is it's just like inducing a labor, mini labor. Okay, right? So mesoprost greater than 12 weeks, you can give this mesoprost, which is a prostaglandin analog, PGE1 analog, right? Here what will be the dose of mesoprost in second trimester medical abortion? What is the dose of mesoprost? It is 400 micrograms of mesoprost you will give vaginally. Okay, via pervaginal route you will give this mesoprost. Every 4th hourly you will ask the mother to take this tablet, maximum 5 doses. Okay, maximum 5 doses can be given, and that will induce the contractions, and it will automatically mother will get aborted. Okay, right. So this is medical management, medical abortion. Coming to the surgical methods, what are all the surgical methods that we have to perform abortion in second trimester? In second trimester, yes, you can go with dilatation and evacuation, right? You can go with dilatation and evacuation using ovum forceps, right? You can perform dilatation and evacuation. If not, hysterotomy can be done. If not, hysterotomy can be done. These are the surgical methods that you can follow in case of second trimester abortion. Okay, 1. Dilatation and evacuation using ovum forceps. What is ovum forceps? Again, it is an IBQ. Again, it can be asked as an IBQ. How you will identify ovum forceps? Hello, what are the identification features for ovum forceps? How will you identify ovum forceps? See the image carefully. See the tip, this one. The tip of the ovum forceps, see here it is spoon shaped, right? And see the handle here, it does not have any ratchet lock here. It is similar to that of your cheatal forceps. Even cheatal forceps will not have lock, and this also ovum forceps also will not have any lock here. So that are the identification marks for ovum forceps. Okay, it is spoon shaped and it will not have any ratchet lock. Okay, right. So dilatation and evacuation using ovum forceps followed by a blunt curettage. Okay, you will do a blunt curettage after evacuating the uterus with ovum forceps. You will do a blunt curettage in all pregnancies. In all pregnancies, like where you are performing abortion, it should be done blunt curettage. But whereas in case of, there is an exception, whereas in case of molar pregnancy, just now I'll be coming to the molar pregnancy. Please remember this. This is very important. In all pregnancies, you will be doing blunt curettage except in case of molar pregnancy. In molar pregnancy, after suction evacuation, you are going to do sharp curettage. Okay, you are going to do sharp curettage, and that curettings will be sent for histopathological examination. Anyway, I'll come to that within a while. Please listen to this. Second trimester abortion, dilatation and evacuation you are going to do with ovum forceps followed by blunt curettage in case of all pregnancies except molar pregnancy. In molar pregnancy, yes, you are going to do a sharp curettage, right? Okay, and the another method which we have apart from dilatation and evacuation is hysterotomy. What do you mean by hysterotomy? This is not hysterectomy. Hysterectomy is different. Hysterotomy is, otomy means opening. Okay. Hysterotomy means you are going to give an incision parabdominally and remove the products of conception, right, before the period of viability. That is the that is what do you mean by hysterotomy. Okay. You will make an incision parabdominally and remove the products of conception out, right? So are you clear? These are the methods of abortion in first trimester and second trimester. Okay, very, very important. So done with abortion. Do you have any doubts till now? Any doubts till now? So today's class will be little bit longer after a very long time I'm taking. I have planned for a lengthy session. So today's session will be little bit longer. I want you people to okay, be patient and just listen and prepare your notes. Okay. Okay. Any doubts till now? Am I going fast? Should I reduce the speed? Just give me some time. Okay, right. If I want to slow down, yes, I'll slow my speed. If not, I'll continue in the same speed. Okay. Thank you for your response, Satish, Yamuna and Mercy. Vinita, thank you so much. Okay. So now coming to the ectopic pregnancy, again one of my favorite topic, ectopic pregnancy. Okay. See, what do you mean by ectopic pregnancy? I want you people to answer. See, ectopic pregnancy is, okay, ectopic pregnancy is, see, implantation of blastocyst, usually where your blastocyst has to get implanted. So here the fertilization happens, right? Here like in fallopian tube, fertilization happens at the level of ampulla, right? Here zygote gets formed and it has to come into the lining of the uterus and it will get implanted in the uterus. This is what happens in normal pregnancy. This is what happens in normal pregnancy. But whereas in case of ectopic pregnancy, it will not get implanted here. Okay, it is getting implanted outside the uterus, somewhere outside the uterus, extrauterine. Okay, that is called as ectopic pregnancy. See, that is what I have written here. Implantation of blastocyst other than the uterus is called as ectopic pregnancy, right? And there is one more term that you need to remember, that is called as heterotopic pregnancy. What do you mean by heterotopic pregnancy? Ectopic pregnancy, you are clear, right? Implantation of embryo, this blastocyst other than the uterus is called as ectopic pregnancy. But what do you mean by heterotopic pregnancy? Is nothing but twin pregnancy. It is nothing but twin pregnancy. But whereas here this is not exact twin pregnancy which you are thinking about. Here one will be growing, one will be intrauterine, one will be intrauterine and the other one will be extrauterine. So one blastocyst will be growing within the uterus, the other one will be growing outside the uterus. Okay, that is what it meant. It is meant with heterotopic pregnancy. Heterotopic pregnancy means it's a twin pregnancy where one blastocyst will be getting implanted within the uterus and one there is one more blastocyst which is growing outside the uterus. Okay, so one is intrauterine and the other one is extrauterine. Okay, that is what is meant with heterotopic pregnancy. Okay, understood the differences between ectopic pregnancy and heterotopic pregnancy? Again, they can ask you this in your exam as MCQs. Okay, right. Yes, there are two embryos, one in uterus and one is outside the uterus. Right. Now, before going into the topic of ectopic pregnancy, I want you people to answer few questions on anatomy of fallopian tube. Okay, let me check your anatomy knowledge. Okay, see this is how the fallopian tube appears, right? I've already given the markings. Number one, the fingers like structures, this one, the finger like projections is called as fimbriae, right? And just here, the second part, the distal end of the tube is infundibulum, which infundibulum, above which is your ampulla, and then the longest portion is your isthmus, and then just the part which is just in contact with the uterine cavity is called this part. This part is called as intramural part, or it is also called as interstitial part, interstitium, right? You are clear till here? These are the parts of fallopian tube. Now, be quick in answering. Quickly answer me, what is the length of fallopian tube? What is the length of fallopian tube? Yes, what is the length of fallopian tube? What is the length of fallopian tube? Yes, it is 10 to 12 centimeters. And fallopian tube is lined by dash epithelium. What type of epithelium is present in fallopian tube? Yes. What type of epithelium? It is columnar, ciliated columnar epithelium. Ciliated columnar epithelium is present in fallopian tube. Excellent, Vinita, you are right. And this, what is the site of fertilization in fallopian tube? What is the site of fertilization in fallopian tube? It is ampulla. Ampulla, this one. This one. This is the site of fertilization. Okay. That is the site where ovum comes in contact with the sperm, and that is the area where zygote gets formed. Okay. Ampulla. Site of fertilization in fallopian tube is ampulla. Most common site for ectopic pregnancy, tubal site. Most common tubal site for ectopic pregnancy is, I already told you, it is ampulla. Why it is the most common most common site in fallopian tube? Because that's the site of fertilization. Because that is the site of fertilization. That is the area where fertilization happens. Okay, so that is why that is the site, most common site for ectopic pregnancy, tubal ectopic pregnancy. Now tell me for most non-tubal ectopic. What is the most common site for non-tubal ectopic pregnancy? Non-tubal ectopic pregnancy. Yes, be quick in answering. Ovary. Excellent, Suha. It is ovary. Okay, that will be the most common site, which is non-tubal site. Okay, right. And what is the narrowest part of the fallopian tube? Which is the narrowest part of fallopian tube? Yes, tell me, what is the narrowest part of fallopian tube? Narrowest part of fallopian tube is excellent. It is not isthmus, Suha. It is intramural part. Okay, it is interstitium or intramural part. It's one and the same. Second narrowest is your isthmus. Okay. Now, there are two sphincters in fallopian tube. Okay, anatomical each fallopian tube has anatomical sphincter and physiological sphincter. Can you tell me which is the anatomical sphincter in fallopian tube? Can you tell me anatomical sphincter? Which is the anatomical sphincter in, yes, excellent, interstitium. Excellent, Moni. It is interstitium, that which act as an anatomical sphincter, which is a physiological sphincter. Physiological sphincter. Yes, be quick. Which is a physiological sphincter in fallopian tube? Yes, isthmus. Okay, right. Excellent, Arun. It is isthmus. Now tell me, what are the special cells that are present in fallopian tube? Do you remember? PEG, PEG cells. PEG cells. These are the special cells which are present in case of fallopian tube. Excellent, Vinita. PEG cells. Right. Now, see, let us come to the risk factors of ectopic pregnancy. Now, done with the anatomy of your fallopian tube, come back to the ectopic pregnancy. What are the risk factors of ectopic pregnancy? Most common risk factor. Tell me the most common risk factor. Here they are asking you the most common risk factor of ectopic pregnancy. Excellent. It is PID. It is PID. Pelvic inflammatory diseases is the most common risk factor for ectopic pregnancy. Now tell me, what is the what are the conditions that are associated, that means which are maximum risk is seen with, maximum risk is associated with, maximum risk of developing ectopic pregnancy is seen with what conditions? Excellent, Arun, you are 100% right. It is previous history of ectopic. That's a maximum, I am telling you. Maximum means, okay, there is a history of ectopic pregnancy. Again, there is a high chances of getting ectopic pregnancy in the present pregnancy also. That is what meant by maximum risk of maximum risk. Okay, maximum risk is associated with previous history of ectopic pregnancy or tubal surgeries. So these are the conditions where there are maximum risk of developing ectopic pregnancy. Suppose if a female had undergone had ectopic pregnancy and had undergone had a medical management in her previous pregnancy, and in present pregnancy also there are high chances of her to develop ectopic pregnancy or to have ectopic pregnancy. Okay, yes, the most common will be PID, pelvic inflammatory disease, but the maximum risk of ectopic pregnancy is associated with previous history of ectopic or tubal surgeries. Why tubal surgeries? I already told you what is the epithelium that is present in tubes, fallopian tubes, ciliated columnar epithelium, right? When this cilia get damaged, there are high chances of ectopic. So that is what. Okay. Now, what is the outcome? See, ectopic pregnancy has to end. Okay, it has to end. Okay, by the end of first trimester, it has to end. Usually, it will get aborted or ruptured. Okay, something has to happen. Okay, it has to get aborted, or either the tube will either it will go undergo abortion, or the tube will get ruptured. These two things will happen in ectopic pregnancy. Okay, that is what is the outcome of ectopic pregnancy. Okay, either abortion or tube rupture. Okay, right. Most common site where tubes undergo abortion is where the tubal abortion occurs is, okay, the most common site where tubal abortion occurs is ampulla. In ampulla, suppose there is an ectopic growing in ampulla, so the outcome of that will be abortion. But whereas in isthmus, if it is growing, if the ectopy is growing, the outcome will be rupture. Okay, right. Please remember, A for abortion, A for ampulla, and rupture is isthmus. So that is the narrowest part, right? If narrowest part of the tube, right, easily get ruptured. Okay, anything narrow easily get ruptured. So that is the very narrow. Isthmus is the narrowest part of the tube, second narrowest part, right? So that is, now you will start asking me why not interstitium, because why not interstitium is, just now I told you interstitium is closely in contact with the uterine cavity. From uterine cavity it will be getting nutrition. So the zygote which is growing here, okay, in intramural part, it will get nutrition from the myometrium of the uterus. So that's why it is late to rupture. Okay, it is late to rupture. The second narrowest part of the fallopian tube is isthmus. So isthmus, any ectopic growing in isthmus will undergo rupture. Okay, I mean earliest to rupture. Okay, so that is the outcome of ectopic pregnancy. Either it has to get aborted or it has to undergo rupture. Okay, tubal abortion or tubal rupture. Only these two things can happen, right? So suppose I am giving you a case. Now there is a woman, there is a pregnant woman. Okay, carefully listen to this. Yes, you have already cleared half of the exam, and congratulations to all those who have cleared prelims. Okay, see, your consistency, your perseverance, your hard work had helped you, and that's how you have secured, like you have cleared your prelims, and maintain the same consistency, maintain the same have the same perseverance. Okay, you can also clear this mains. Okay, be positive and give your 100%. Rest of the things leave to the nature. That's enough. Yes, nature is going to bless you with a nice gift, okay, for your hard work. Okay, but be consistent. So now there is a case. See here, now there is a case. Now the tube got ruptured. Let's suppose now the tube got ruptured. I told you, right, only two things can happen. Either the tube has to go under abortion or rupture, right? So let us take rupture. So now the tube, fallopian tube, got ruptured, right? Once the tube gets ruptured, then immediately I am going to call it as ruptured ectopic pregnancy, right? So what happens in ruptured ectopic pregnancy? The tube got ruptured and internal bleeding is happening into the peritoneum. Okay, what do we call? Hemoperitoneum. Bleeding is happening into the peritoneal cavity, hemoperitoneum, right? So what will be the signs and symptoms in hemoperitoneum? Suppose the tube got ruptured in a pregnant woman, and all the blood is getting collected into the peritoneal cavity, right? So yes, excellent. What will be the signs and symptoms? As Suha rightly said, it is Danforth sign. Yes, I am going to see Danforth sign in the client. I am going to see Danforth sign, which is nothing. Danforth sign is nothing but, see, blood is where the blood is getting collected. It is getting collected in the peritoneal cavity, right? Which is this peritoneal cavity, like just above the what is dividing abdomen from the chest? Diaphragm, right? So the blood which is getting collected in the peritoneal cavity will irritate the diaphragm, and the pain will radiate to the tip of the shoulder. So that is called as Danforth sign. And next one, as Pranita, yes, and Thirumal Rao has rightly answered, Cullen's sign. I am also going to see Cullen's sign. What do you mean by Cullen's sign? Bluish discoloration around the umbilicus is called as Cullen's sign. Along with Danforth sign, I am also going to see one more sign which is called as Cullen's sign. Cullen's sign is nothing but bluish discoloration around the umbilicus is called as Cullen's sign. And obviously there will be pain, right? Obviously there will be pain, right? And pain in abdomen. And apart from that, any other symptoms, any signs and symptoms? See, yes, Pranita is telling something. Pouch of Douglas, right? See, See here, here the tube got ruptured. The bleeding is happening into the peritoneal cavity. What is this? This is uterus and this is the rectum. Okay, in between uterus and the rectum there is a peritoneal sac which is called as rectouterine pouch or pouch of Douglas or cul-de-sac. It's one and the same. When I say rectouterine pouch, when I say cul-de-sac, when I say POD, pouch of Douglas, it's one and the same. Okay, so between the rectum and uterus you have a small sac, empty sac, sac which is called as, which is nothing but folding of your peritoneum, that is called as rectouterine pouch. Okay, there is an empty space. So the bleeding which is happening will go and start getting collected in the POD there, right? It will go start getting collected in the rectouterine pouch and okay. So what is there just behind the this POD? What is there? Rectum, right? Okay, so it will exert the pressure on rectum. So the blood is getting collected. Excessive bleeding happens, right? And in tubal rupture, the blood is continuously getting collected in POD, pouch of Douglas, and the pressure. So the size also will get increased, right? So it will exert some pressure on the rectum, and female will experience the urge to defecate. Okay, the urgency of defecation will be there in female. So urge to defecate will be there in case of pregnant women. In case of ruptured ectopic pregnancy, sorry. Okay, next, also the patient will have bleeding, shock, right? Obviously what you will experience, hypotension, orthostatic hypotension. The patient will have orthostatic hypotension. So these are all the signs and symptoms that I am going to see due to hemoperitoneum in case of ruptured ectopic pregnancy, right? So just now I told you, right, there is excess of bleeding happening in case of ruptured ectopic pregnancy. How does the patient comes to you? The patient will come to you in shock because bleeding, she is bleeding internally, right? So she will come to you in shock. If you see her, how you will identify shock? Just see her heart rate. Heart rate will be high. In compensatory phase, heart rate will be high, right? Compensatory shock, right? Initially the compensatory shock, tachycardia will be there, right? So patient comes to you in shock. And what about BP? BP will fall, hypotension, right? Bleeding, no volume at all in blood vessels. So then how BP will be maintained? So BP will be less, there will be hypotension, low BP. Patient comes to you in shock. Obviously, what do we see? It's same everywhere. It's not only in obstetric, it's same everywhere, tachycardia and hypotension, right? So along with this, you're also going to see this tachycardia and hypotension, right? Very, very important. And when you do per abdominal examination in case of this ruptured ectopic woman, so just now I told you, right, there is a ruptured ectopic woman. Okay, so if you do a per abdominal examination in her, so you will see her, obviously blood is getting collected in peritoneum, obviously abdomen will get distended, there will be abdominal distension on per abdominal examination, and obviously tube got ruptured, the mother will have tenderness, okay, rebound tenderness. When you press and release, immediately the mother will, the patient will wince with pain, okay, that is called tenderness, rebound tenderness, right? And along with that there is guarding and rigidity which are present in case of ruptured ectopic pregnancy. Again I am telling you, on per abdominal examination there is a ruptured ectopic client who came to the emergency in shock, okay, and there is Cullen sign, Danforth sign, everything. And when you have done per abdominal examination on that woman, okay, you will see guarding and rigidity. Along with that guarding and rigidity, abdomen, obviously blood is getting collected into the peritoneum, the abdomen will get distended, and along with that there will be rebound tenderness in case of ruptured ectopic pregnancy. This will be the findings on per abdominal examination. And when you do PV examination, per vaginally. What are the findings you are going to get in a case of ruptured ectopic pregnancy? As soon as you as soon as you insert the fingers and touch the cervix, the mother will shout like she will scream with pain. Okay, she's going to scream with pain pain. That is called as cervical motion tenderness. Cervical motion tenderness. Okay, on pervaginal examination, as soon as the fingers come in contact with the cervix, the mother is going to the mother is going to experience the pain. She's going to scream with, okay, that is called as cervical motion tenderness. This will be the finding on PV examination. And along with that, when you feel for the adnexa on PV examination, you will feel some mass. That is nothing but blood is getting collected, right? You can see some that adnexal mass. Okay, the most important finding on PV examination is adnexal mass. Okay, in ruptured ectopic pregnancy on PV examination, the most important finding is adnexal mass. Okay, and along with that, the mother will also have cervical motion tenderness. As soon as you insert your fingers into the vagina, and as soon as your fingers come in contact with the cervix, as you try to move the cervix, mother is going to scream with the pain. So that is called as cervical motion tenderness. These are the findings okay, in a ruptured ectopic woman. Okay, right. So along with these signs and symptoms, just now I told you, right, all that I've already told you the signs and symptoms, right? So along with all of this, there will be ectopic triad. Okay, don't forget ectopic triad, obviously. What is ectopic triad? Tell me, what are the triad symptoms that you are going to see in a client of whatever it may be, ectopic, ruptured or unruptured? You are going to see this triad. What is that? Excellent, Pranita. It is BPV, bleeding per vaginum, and amenorrhea. There will be amenorrhea, 6 to 10 weeks of amenorrhea. Okay, and abdominal pain in abdomen. Okay, so these are the triad symptoms. Along with those symptoms which I have explained you till now, along with those symptoms, you are also going to see this triad symptoms in case of ectopic pregnancy. Either ruptured ectopic pregnancy or ruptured ectopic pregnancy, you are going to see this triad symptoms. Okay, right, present in both the types of ectopic pregnancy, right? Don't confuse. Ectopic pregnancy, you have to remember the triad: pain, bleeding, and amenorrhea. That will be the main complaints. Okay, now I already told you, right? I already given you a case. There is a woman who came to you and the tubes got ruptured and she is bleeding internally. So how does she come to the clinic? Yes, she comes to the hospital in shock. During that time, what will be your investigation of choice for ectopic pregnancy? Yes, obviously you have to do ultrasound, but not in case of ruptured ectopic. Okay, but not in case of ultrasound. It will take time. That is a time taking procedure which is not advised in case of emergency conditions. Okay, transvaginal sonography, it is not done. But whereas one important procedure which is done in case of ruptured ectopic to confirm the diagnosis is culdocentesis. Okay, usually what do we do is, usually what happens is, whenever there is triad symptoms, and along with that, I think I have a case here. No, I don't have a case. Okay, so suppose if there is a woman who came to the emergency, where there is amenorrhea, bleeding per vaginum, and pain in abdomen, and along with that, on perabdominal examination, there is guarding and rigidity present, and abdominal distension and rebound tenderness present, and her vitals are unstable. Then what you will do is, if guarding and rigidity are present, then what immediately clinician will do is, okay, this is what usually they follow. Okay, if guarding and rigidity, they will check for guarding and rigidity along with those symptoms which I have explained you till now, right? If guarding and rigidity is present, then fast, okay, which is nothing but ultrasound. This is done, okay, and which you can identify the fluid in pouch of Douglas, right? And immediately they will take for the surgery. Okay, they will do this ultrasound called fast, and they will take immediately to the surgery. Okay, laparotomy need to be done, right? So, right, but yes, you can also do this procedure which is called as culdocentesis. What do you mean by culdocentesis? It's nothing but you are inserting a needle into the cul-de-sac. What is cul-de-sac? I already told you, just behind the uterus and in front of rectum there is a small sac which is present, right? There is which is called as recto-uterine pouch or cul-de-sac or pouch of Douglas. In ruptured ectopic pregnancy, blood gets collected in all over the peritoneum, right? So there also blood gets collected. More blood gets collected in POD actually. Okay, so what happens is you will take a syringe and you will with needle, and then you will, via the posterior fornix of the vagina, you will insert this needle into the recto-uterine pouch or POD, right? And you will aspirate the blood. POD, what is happening? Hemoperitoneum, blood is getting collected in cul-de-sac, right? So you will aspirate that blood, and then you will take that syringe out and keep it aside. You will aspirate the blood, you will pull back the syringe, you will remove the needle from there, and then you will just keep the syringe for some time aside. Okay, if the blood is not getting collected after keeping aside, then that will confirm the diagnosis of ectopic pregnancy. If the blood is getting clotted when you keep it aside for some time, if the blood is getting clotted in the syringe, then if the blood is getting clotted, then it is not then that means you have entered any blood vessel. Okay, if the blood is not getting collected, then that means it is ectopic pregnancy. So blood is not getting clotted. Suppose you have aspirated the blood from POD and you kept the syringe aside for some time, and if the blood is not getting clotted, then that will confirm the diagnosis of ectopic pregnancy, which is called as the procedure which I have explained you is nothing but culdocentesis. Okay, the procedure which I have explained you just now, the entire kahani just I told you right now is nothing but culdocentesis. Okay, remember it is non-clotting blood. Okay, non-clotting blood you need to get in the syringe when it is kept aside. It is called as ectopic pregnancy. Then that will confirm the diagnosis of ectopic pregnancy. If the blood gets clotted once you keep it aside for some time, then you have aspirated the blood from the any vein or any blood vessel. Okay, any artery. Okay, so that is not that will not confirm the diagnosis. Okay, if it is from pouch of Douglas, if it is a blood from pouch of Douglas, it will not clot. Okay, it shouldn't be clotting, right? And the procedure which I have explained you till now is called as culdocentesis, and again this can be asked as an IBQ in your exam. Okay, and again this can be asked in exam. Okay, they'll give you this image, and what is the procedure they can ask you. This procedure is nothing but culdocentesis, where you will insert the syringe into the needle into the cul-de-sac via the posterior fornix of the vagina, and you will aspirate the blood to confirm the diagnosis of ectopic pregnancy, mainly the ruptured ectopic pregnancy. Okay, so right. And how do you manage a ruptured ectopic pregnancy? Tube got ruptured. You and me cannot do anything, right? Just you will the remaining tube and the leftover part should be surgically removed. Okay, we'll cut the tube and remove. That's it, right? unilateral, you will do a procedure which the surgery which you are doing here is unilateral salpingectomy. Unilateral salpingectomy. Okay. Please don't answer salpingo-oophorectomy. It is never done in case of ruptured ectopic pregnancy or ectopic pregnancy. Okay, the one which is done here is in ruptured ectopic pregnancy, tube got ruptured. Now you cannot sit and attach the tube. It is impossible. Okay, so what you will do is you will just cut the tube and remaining tube and you will throw it out. Like you will remove it out. Okay, so what is that surgery called? Salpingectomy. Okay, salpingectomy. Both the tubes you will not remove, only the tube which got ruptured you are going to remove, since it is called as unilateral salpingectomy. Okay, right. Linear salpingostomy family is completed. What is this? No. I'll come to you. I'll come to you. Linear salpingostomy. I'll come to you. Linear salpingostomy is never done. Only one surgery which is done in case of ruptured ectopic is unilateral salpingectomy. No other surgery is done here. No other surgery is done here. No salpingostomy. Linear salpingostomy is never done in case of ruptured ectopic. You cannot do also. Okay. Only one option is salpingectomy. Okay, right. If it is ovarian ectopic, yes, you can do oophorectomy. Okay, if question says ovarian ectopic, then oophorectomy is allowed. Oophorectomy need to be done. Oophorectomy need to be done. Okay, right. So always remember, in ruptured ectopic, please don't answer linear salpingostomy or medical management, conservative management. Nothing to do with expectant management or medical management in case of ruptured ectopic pregnancy. In ruptured ectopic pregnancy, it is always surgical. You are going to cut the remaining tube, the damaged tube, and throw it out. Unilateral salpingectomy is the one that is the one which you are going to perform, right? If it is ovarian ectopic, yes, you can go for oophorectomy, right? But always remember, it is salpingectomy. You are going to cut the tube and remove it out. So now, linear salpingostomy, I told. See, linear, again I am telling you, linear salpingostomy, it is not done in case of ruptured ectopic. Ruptured ectopic, it is always salpingectomy. Because, my dear Aishwarya, please understand this. In ruptured ectopic, the tube got ruptured in such a way that it cannot be repaired at all. Okay, it cannot be, we cannot bring back the anatomy once again, right? You are not God, you cannot bring the anatomy once again. So what you will do is, you will just cut the damaged tube and remove it out. Okay, that is what, it is done in case of ruptured ectopic pregnancy, and the surgery is called as salpingectomy. Linear salpingostomy is never done in case of ruptured ectopic pregnancy. Please do remember this again. Okay, I think Aishwarya, your doubt is clear now, right? Now, okay, just tell me, there is a case here, there is a female with 8 weeks of amenorrhea, pain in abdomen, and her UPT is positive. Okay, also experiencing spotting, and vitals are unstable. And tell me, what will be the next step in this case? What will be the next step in this case? Tell me, what is the next step as a nursing officer, what you are going to do in this case? Female with 8 weeks of amenorrhea, pain in abdomen, her UPT is positive, that there is a triad symptoms of ectopic, yes, that confirms ectopic, also experiencing spotting. The triad symptoms are present, right? Along with that, UPT is positive, that means she is a pregnant and ectopic pregnancy, right? Vitals are unstable, her vitals are unstable. Unstable means she is in shock. That means tubes got ruptured ectopic pregnancy. Now what will be your next step? Next, tell me what will be your next step? Excellent, Aishwarya, excellent, you are right. As a nursing officer, see, vitals are unstable, the patient is in shock. Immediately you start resuscitating the patient, you will give fluids, and right. So immediately you have to see, first of all, you will not go for laparotomy. First you will manage the case, you will resuscitate the case, and then go for laparotomy. Okay, first you will resuscitate the client, and this is how priority based questions come in your NORCET exam. Okay, you will confuse and select the option laparotomy, but laparotomy is not the next step here. Next step should be resuscitation, and after resuscitating, once you resuscitate the patient, then you will take the patient to the laparotomy. Then you will perform laparotomy, right? So it is resuscitation followed by laparotomy. Okay. Now coming to the unruptured ectopic. So now coming to the unruptured ectopic, just tell me how you are going to manage this case. So any doubts? Somebody is telling. What will be the management of unruptured ectopic pregnancy? I'm not going into this. Now don't tell me yes. What will be the management of unruptured ectopic pregnancy? Yeah, okay. So, okay. Keep it aside. Let me come to that later. Again here, even I already told you, right? Ectopic pregnancy means there will be, yes. Now you can start answering linear salpingostomy. Okay, linear salpingostomy. Yes. Now you can start answering whatever it may be. Yes, now you can answer methotrexate, linear salpingostomy, ectomy, everything. But there only one surgery. Okay, only one surgery. Ectomy is done. Unilateral salpingectomy is the one that is done in case of ruptured ectopic pregnancy, right? But here your options are right. Okay. So now unruptured ectopic pregnancy also, see, now tell me how an unruptured ectopic pregnancy can come to you. Unruptured ectopic pregnancy, how she can come to the clinic? Tell me. There is a case of unruptured ectopic pregnancy. Unruptured ectopic pregnancy, somewhere, let's suppose ovary. In ovary, ectopic is growing, and it okay. Or take fallopian tube. In fallopian tube, in ampulla, ectopic is growing, and still it got it has not ruptured. And how can the patient come to the clinic? Emergency, UPT positive bleeding. Yes, the patient can come to you with this BPV, bleeding per vaginum. Yes, in a case of unruptured ectopic pregnancy, the patient will come to you with bleeding per vaginum, right? And there will be amenorrhea and there will be pain in abdomen. Okay. So don't confuse. You will see bleeding in both, right? There will be vaginal bleeding in both. The patient will come and tell you bleeding per vaginum in both ectopic, ruptured ectopic and unruptured ectopic. Don't confuse that only in ruptured ectopic you are going to see bleeding. You will also see bleeding in case of unruptured ectopic pregnancy also, right? Okay. Now, now tell me what are the investigations that you are going to perform in case of ectopic pregnancy. Yes, tell me what are the investigations that you can do is, see, the investigation of choice in ectopic pregnancy is transvaginal sonography. Okay, transvaginal sonography. And what do you see on scanning? What do you see on ultrasound is, see here, uterus will be empty. That is what is ectopic pregnancy, right? Ectopic pregnancy is baby is growing outside the uterus somewhere, right? right. So uterus is empty here. Uterus will be empty on scanning, and there will be pseudo gestational sac in the uterus. You will see a pseudo gestational sac, a fluid filled sac. Pseudo gestational sac is seen in case of scanning in a case of ectopic pregnancy, unruptured ectopic pregnancy, right? And and when you focus the probe on adnexa region, when you focus this probe transducer on the adnexal region, see how the how it appears is, how the scan appears is, carefully see this scan. Okay, there is a small sac here which is nothing but your G sac. This is your G sac, and this G sac is surrounded by a hyperechoic ring, this one ring, which is giving you appearance of a donut, sugar donut, right? So that's why this is also called as sugar donut sign, or blob sign, or bagel sign. Okay, please do remember, if any question is giving you this hint, okay, on scanning there is blob sign seen, bagel sign seen, sugar donut sign seen, is nothing but it is talking about unruptured ectopic pregnancy. Okay, now now the radiologist is performing the scanning. Okay, radiologist got this sugar donut sign. Now what the radiologist will do immediately is he will switch on the color Doppler. Okay, there is an option called Doppler in case of ultrasound, though he will click on it. So what happens is immediately he will start seeing blood vessels. See here, blue and white. So these are nothing but blood vessels, right? So it is forming a ring. It is forming a ring here, right? Around this G sac. It is nothing but G sac of blood supply. Okay. So this is called as, this specific appearance on color Doppler is called as ring of fire appearance. Ring of fire appearance. Okay. So these are the findings that can be seen on an transvaginal sonography in unruptured ectopic pregnancy. Okay, in ruptured ectopic pregnancy obviously will not sit and see all these signs. Okay, whether uterus is empty or whether I am finding pseudogestational sac. Okay, patient is in shock in case of ruptured ectopic pregnancy, where you have to take, you can do a fast and take for the operation theatre, or you can go with culdocentesis. Okay, right. But whereas here you have time, right? So you'll go with the scan, transvaginal scan. On transvaginal scan, what all you are going to see is, yes, the uterus will be empty, and you are going to see a pseudo gestational sac in the uterus. And if you focus the transducer on adnexa, and on adnexa will appear like this, sugar donut sign. G sac surrounded by a hyperechoic ring is nothing but donut sign or bagel sign or blob sign. It's one and the same. Okay, right. And on color Doppler studies you will see ring of fire appearance. Okay, but all these signs which I told you, uterus empty, pseudo gestational sac, bagel sign, ring of fire appearance, they are not confirmatory of, they are not 100% confirmatory. Why I told you this is, yes, they are seen in case of unruptured ectopic, but they are not 100%, they will not confirm the diagnosis of ectopic pregnancy. They will not 100% confirm the diagnosis of ectopic pregnancy. All these signs. The one which will confirm ectopic pregnancy on scan is, you have to see G sac. Along with that, you also should see yolk sac, with or without fetal heart rate, I mean cardiac activity. I mean cardiac activity, with or without cardiac activity. This will 100% tell me, yes, there is an ectopic growing there. Yes, there is an, if I see this in a tube, yes, I'll confirm that, yes, it's a 100%, there is ectopic growing in the 100% ectopic growing in the tube or somewhere else. Okay, right? I should able to see G-sac, in which I should also see yolk sac, and with or without cardiac activity. This will be the confirmation. 100% it will confirm ectopic pregnancy. Now, now coming to Sushma Kiran, I am coming to you. Just wait. Beta HCG alone will not confirm the diagnosis. Initially, you have to do transvaginal sonography. Okay, initially you will not do beta HCG levels. Okay, suppose if any patient comes to you with bleeding, immediately you will not check, you will not do beta HCG levels, right? You have to do scanning and see, you have to differentiate. Okay, see the clinical scenario, correlate with the clinical things, and then you will come to the beta HCG levels. Just now I'll tell you how to diagnose unruptured ectopic pregnancy. I'll just tell you. Okay, you will do scanning. So you will do, in first trimester we do obviously transvaginal scanning. Okay, on transvaginal scan, just now I told you, right, if you see G-sac plus yolk sac, if you see G-sac plus yolk sac with or without cardiac activity in fallopian tube, yes, that will confirm 100%, that will confirm, yes, this is a case of ectopic pregnancy. Then you can proceed with the treatment of ectopic pregnancy. Then you can proceed with the treatment of ectopic pregnancy, right? So G-sac with plus yolk sac and cardiac activity I am seeing in, with or without cardiac activity in, if I am seeing in a fallopian tube or somewhere else, yes, that will 100% confirm ectopic pregnancy, right? And then directly you can go for the treatment of ectopic pregnancy. But whereas here, okay, but there is one more case where I cannot able to see G-sac, where I cannot able to see yolk sac, but there are some signs which is making me suspicious to think of ectopic pregnancies. For example, empty uterus. For example, empty uterus, but her UPT is positive. Why can't I think of ectopic pregnancy? I'll think of ectopic pregnancy, right? But I cannot able to see G-sac, yolk sac. But yes, this is making me little bit suspicious. Okay, what all I can think of is, yes, here in that situation, what I'll think of is, I can think of, yes, this might be a ectopic pregnancy, right? This can be a abortion, right? Uterus is empty means aborted and she came with a bleeding. Abortion ho sakta hai, right? So abortion, and it can be in early intrauterine pregnancy. See, early intrauterine pregnancy, what happens is, early intrauterine pregnancy means there's a G-sac which is like growing, there's a fetus, there's a small G-sac which is growing in uterus, which cannot be picked up in ultrasound. So because it's very, very small, in early intrauterine pregnancy, the sac will be very, very, very small, which cannot be picked on ultrasound. So in that case also I'll be suspicious, right? Okay, uterus is empty, so I can think of all these conditions, right? So ectopic pregnancy you can think of abortion, you can think of early intrauterine pregnancy, right? So now how to differentiate? Now somebody is telling beta HCG, right? Vinita, yes. Now how to differentiate all these things is, yes, now I will do an beta HCG level, okay, beta HCG, and then okay, I'll check. What do I check? Why should I monitor beta HCG level? What for? I'll check for the critical level, something called critical level. What do you mean by critical level? See, critical value is that value where, okay, is that value of HCG where in all intrauterine pregnancies, Okay, if that value is present if that value is present, I should able to see the G-sac in the uterus. The G-sac will become visible in the uterus. This is an universal law. Okay, this is an universal law. Okay, for TVS it is 2000 international units. That means I have taken the sample of the woman, beta HCG is around 2000 international units, and if that means I should able to see G-sac in her uterus on ultrasound, that it should be, it will become visible. Okay, by if the HCG is at 2000 international units, on transvaginal scan it will become visible. That is the meaning of critical value. Okay, if I have monitored beta HCG level, if the critical value is 2000 international units and still I cannot able to see gestational sac, okay, if the beta HCG level is 2000 international units, I can think of ectopic pregnancy and I can proceed with the treatment of ectopic pregnancy. I've already told, right? See, critical value is 2000, that means G-sac should be visible in uterus in all intrauterine pregnancies, but whereas here beta HCG is 2000, but on ultrasound I cannot able to see G-sac. That means G-sac is growing somewhere else other than the uterus, right? Ectopic pregnancy, I can think of ectopic pregnancy and start with the treatment of ectopic pregnancy. If it is not an ectopic pregnancy, if the critical value is not achieved, okay, if it is not above the critical level, then I have to, I'll be waiting for 2 days. I have to wait for 2 days and repeat beta HCG levels after 2 days. Okay, if the beta after 2 days, if beta HCG got doubled, then that means it's an intrauterine pregnancy. If it is slow, if it is increasing but it is slowly rising, which is less than 66%, then I'll think of ectopic pregnancy, right? Okay, see, if the values are, if the beta HCG value is not above the critical value, then what I will do is, then I'll wait for 2 days, and after 2 days I'll check her beta HCG once again. If her beta HCG got doubled, okay, more than 66%, then I can think of, yeah, it's an intrauterine pregnancy I should think of. If it is less than 66%, you can think of ectopic pregnancy, which is slowly rising. If it got doubled, then you can think of intrauterine pregnancy. If it is here in ectopic pregnancy, it will be slowly rising, slow rise. There will be slow rise in case of ectopic pregnancy. Please don't answer the beta HCG levels are high. It is not in, it will not be seen in ectopic pregnancy. There will be a slow rise. Okay, double aindi ante, that's an intrauterine pregnancy. If it got doubled after 2 days, then it's an intrauterine pregnancy. Increasing, slowly increasing, but less than 66%, think of ectopic pregnancy. If HCG decreases after 2 days, that means female had aborted. Okay, so that's why HCG is going down. Okay, this is how you will differentiate from these 3 conditions and come to a final diagnosis. Okay, yes, this is little bit conceptual, so that's what that's why I want to explain it to you. Now, coming to the unruptured ectopic pregnancy. Now, the management, medical management, and we have surgical management and medical management, right? So now just be quick and just tell me what is the medical management for unruptured ectopic pregnancy? What is the medical management for unruptured ectopic pregnancy? See, which one is more preferred, medical or surgical? For treatment of unruptured ectopic pregnancy, medical is more preferred than surgical. What do we do in medical management? I give an injection. Yes, excellent, Suha, excellent, Aishwarya, Suha, Vinita, yes, I give an I'll be giving an injection called methotrexate. In short form, I can write MTX, means methotrexate. I can give methotrexate injection, right? That's a drug of choice for unruptured ectopic pregnancy. Again, this will be a very important MCQ for your exam. for your RRB or NORCET or whatever it may be, MHSRB, whatever it may be. What is the drug of choice in case of unruptured ectopic pregnancy? In case of unruptured ectopic pregnancy, the drug of choice is methotrexate. Okay, and the dose. Now just tell me the dose. Just tell me the dose. Yes, excellent. It is not 50 mg, my dear Suha. It is 50 mg per meter square or 1 mg per kg. Okay, right? 50 mg per meter square is given. Just remember this: 50 mg per meter square of methotrexate is given intramuscularly. IM. Single dose therapy. In what is the protocol that we follow? Is single dose protocol. Single dose therapy. Okay, single dose therapy. So how this injection is given is, so suppose before giving this injection I should see for few parameters. It is not that you have diagnosed unruptured ectopic pregnancy and immediately you are injecting her methotrexate. Before that I need to see for few parameters. What are those parameters? Yes, can you people tell me what are the parameters that you are going to check in that case? Before giving injection methotrexate, before going to medical management, I should see for few parameters. What are those parameters? Yes, be quick in answering. Yes. Yes, I'll check her vitals. I'll check her for her vitals, and then I'll check her beta HCG levels. Okay, beta HCG levels, and along with that I'll check sac size, gestational sac size on ultrasound, and on ultrasound I'm also going to check for the cardiac activity, and I'm also going to ask the patient whether the family is complete or not. Okay, why should I see for the vital signs before giving methotrexate? See, vitals should be stable for the medical management. Vitals should be stable for the medical management. Okay. And what about the beta HCG levels? If beta HCG, and yes, beta HCG should be less than, yes, Aishwarya, yes, beta HCG, yes, tell me. Yes, Aishwarya had rightly answered. Beta HCG should be less than 5000 international units. Okay, and sac size should be less than, yes, I've already written. Okay, yes, it should be Anusha, yes, you are right. Beta HCG should be less than 5000 international units, and sac size, gestational sac size should be less than 4 centimeters. And what about the cardiac activity? Should be present or absent for medical management? It should be present or absent? It should be present or absent? What about the cardiac activity? Excellent, Aishwarya, it should be absent. Because they say that if cardiac activity is present, okay, there are higher chances of failure to the medical management. Okay, so cardiac activity should be absent for the medical management, and the family should be incomplete. When the family is incomplete or vitals, okay, these are all the criteria for the medical management. Okay, these parameters should be present in the patient before giving injection methotrexate. Okay, now come to the methotrexate. So the medical management will be methotrexate. That's a drug of choice for ectopic pregnancy, unruptured ectopic pregnancy. The dose will be 50 mg per meter square. Route of administration will be intramuscular route. It is given as single dose therapy. Only one injection is given. Okay, for example, today I am giving the injection. On day 1, if I am giving methotrexate injection, Okay, what should I do is, then I'll call her back on day 4 and day 7. I'll call her back on day 4 and day 7, and I'll draw the samples and check for the beta HCG. Okay, beta HCG levels. Okay, between day 4 and day 3, at least there should be greater than or equal to 15% of fall. 15%, greater than or equal to 15%, the beta HCG should get decreased. Okay, greater than or equal to 15% of fall of beta HCG. Okay, should be there. Okay, then that means she is responding to the methotrexate. If the fall is less than 15%, that means you need to repeat the, if the fall is less than 15% between day 4 and day 7, you need to repeat the methotrexate. Repeat methotrexate injection. Maximum how many times you can give methotrexate? Maximum how many times should be you can give methotrexate? Maximum how many times you can repeat methotrexate is 3 times. Excellent, Aishwarya, 3 times. Even though after 3 times of giving methotrexate, if HCG, beta HCG is not decreasing, then what you will do is, then you will opt for the surgical management. So now coming to the surgical management. So now, what will be the surgical management for surgical management for unruptured ectopic? Surgical management will be, see, for ruptured if it is ruptured ectopic, you can, I already told you, there are 2 surgeries that you can perform, right? One is linear salpingostomy. Linear salpingostomy, where I'll make a linear incision on the fallopian tube and then I'll leave it as such. But whereas, yes, linear salpingostomy, right? But whereas one more management is salpingectomy. You can also do salpingectomy. So when you will opt for linear salpingostomy and when you will opt for salpingectomy in case of unruptured ectopic. In case of unruptured ectopic, see, if her family is complete, or if the G-sac is greater than or equal to 5 centimeters, or if that's a case of ruptured ectopic pregnancy, forget about this, I already told you this. If her family is complete or G-sac size is greater than or equal to 5 centimeters, then you will opt for, yes, then you will opt for salpingectomy. Excellent, salpingectomy. Okay. If her family is not complete, or in case of it's a case of unruptured ectopic, then you will opt for linear salpingostomy. Okay. Again, I am telling you, in case of ruptured ectopic, it is always salpingectomy, and in case of her family is her family is complete and her G-sac is greater than or equal to 5 centimeters, then always it is salpingectomy, right? If her family is not complete plus it's a case of unruptured ectopic, then you have to go for linear salpingostomy, right? Okay. Okay. Okay, anyway, I don't want to extend the lecture. I will end here, and then I'll continue the remaining topic in my next class. Okay. I'll continue my next okay, remaining part in my very next class. Okay. So any doubts in today's class? Any doubts in today's class? Yeah, Yeah, I'll be planning all the classes, don't worry. Yeah, any doubt in today's class? I think I have done with my today's class. I think any leftover slide, any slide did I leave? No. Okay. Okay. So thank you so much for attending the live session, and do share the link of this video in all your groups who are preparing for government exams. Surely that will be a support from your side for me, right? Thank you so much. Thank you all for attending the live session, and very soon I'm going to come up with the part 2 part 2 video of this topic, bleeding in early pregnancy. There is few content left in this lecture, so I'll cover that in my very next class. Thank you so much. Thank you all. Good night. Okay, so I think you people don't have any doubts, right, from today's class? Any doubts? Okay, thank you Vinita, thank you all, thank you Sushma, Mercy, Vikram, Krishna, thank you all, thank you so much.